Hello people, this is Dr. Muskaan this side, and today I'm going to discuss one very beautiful case. It is all about TB meningitis. Let's dive deep into this case because I'm going to take you towards pathogenesis because this patient is having fever with chills. So I'm going to tell you in deep why chills has occurred. Okay, so let's enjoy. Here is 18-year-old male who has came to ER with chief complaint of fever, headache and vomiting since morning. On arrival, ABCS was done, airway was patent, there were no signs of airway obstruction. For your knowledge, what are the signs of airway obstruction? Patient feels dysphagia, dysphonia, stridor, hoarseness of voice. He's not able to breathe while lying on bed or while walking. He's holding his neck. सांस नहीं आ रहा, सांस नहीं, he do like this. So these are the signs of airway obstruction. On breathing assessment, respiratory rate was 18 per minute, SpO2 was 98% on room air, so there were no signs of respiratory distress also. What are the signs of respiratory distress? Patient skin becomes pale or cyanosed, there is abnormal breathing, either it is so fast, either it is so slow, either it is too deep or it is too shallow. Patient have gurgling sounds, gasping. So these all are the features of respiratory distress, and when airway obstruction or respiratory distress features are present, what doctor do? They intubate the patient. On circulation assessment, pulse rate was 90 per minute and blood pressure was 120 by 78 mmHg. What we check by circulation? We basically check shock. कि patient shock में तो नहीं चला गया, because generally this is emergency condition only, and there are 5 types of shock, and in every shock there is hypotension and there is tachycardia, except except neurogenic shock, in which there is bradycardia with hypotension. Who knows? They knows. Just learn the table of the shock. You will come to know what I'm telling. Sensorium was alert. GCS was E4, V2, M5, 11 by 15. Eye was opening spontaneously. Verbal response, there was incomprehensive sounds, and on motor responses, he was localizing to pain. HOPI, patient was apparently well 1 month back when he developed complaint of fever, which was insidious on onset, associated with chills and weight loss. There are 2 episodes of green vomiting. There was negative history of hemoptysis with seizures. There was negative history of hemoptysis and seizures. So why chills was occurring in this patient? Basically, there is hypothalamus, which maintains the balance between heat gain and heat loss. Now when temperature is rising to the higher level, heat is being conserved, so patient feels cold and patient starts shivering violently, and because there is restrictions, there is constriction of the cutaneous vessels. Now this shivering may be associated with piloreaction or teeth chattering. When temperature is reached to the highest, heat loss starts and cutaneous vessels dilates for the dissipation of the heat, and the patient feels hot and sweating starts. Okay, so this is the pathogenesis of chills. पहले कंस्ट्रक्शन हो रही है ब्लड वेसल की, बाद में डायलेशन हो रही है ब्लड वेसल की. जब कंस्ट्रक्शन हो रही है तो पेशेंट शिवर कर रहा है, साथ में पायलरेक्शन हो रहा है, साथ टीथ कैटरिंग भी हो रहा है, और जैसे ही वेसल डायलेट करी तो हीट लॉस स्टार्ट हो गया. Past history, patient was admitted with similar complaints in previous hospital and discharged after 7 days. He was diagnosed with TB meningitis there. There is no history of hypertension, thyroid, type 2 diabetes mellitus and tuberculosis. There is no history of any surgical intervention. Personal history, sleep habits are normal, appetite is reduced, and there is positive history of weight loss. Patient is non-alcoholic and non-smoker. There is no addictions to smoking, tobacco, chewing. Okay, bowel and bladder habits are normal. On CNS examination, the positive findings were there was bilateral plantar reflex, which was flexor. Neck rigidity was present. There was presence of 7th cranial nerve palsy because deviation of angle of mouth to the opposite side of the palsy, and eye closing is not proper to the same side of the palsy. There was 3rd cranial nerve palsy because patient cannot move eye up and down. Investigation picture shows CBC reports was normal. KFT report shows hyponatremia, hypokalemia and hypochloremia. LFT picture shows serum transaminitis because SGOT and SGPT levels were raised. But LFT picture shows hepatitis. Now anti-tubercular drugs was going on this patient. So what we do, we stopped all the anti-tubercular drugs and now we are giving drug one by one, because we know that from HRZES, HRE, these HRZ. These 3 drugs are hepatotoxic drug. So if hepatotoxic drug will keep on going on this patient, what will happen? It can lead to liver failure. There will be another problem with the patient. So what we do, we just stop the antitubercular therapy, and we just wait for 3 to 4 days, so that patient recovers from hepatitis, and then we again start a patient on antitubercular drugs. And that also, we just give one drug, and we check who is the culprit, because of which drug there is hepatitis. Okay. So peripheral smear for malaria is negative. Typhoid IgM and IgG was negative. Dengue NS1 antigen. IgG IgM was negative. ECG was showing normal sinus rhythm. Ultrasound abdomen was showing mesenteric lymph nodes. HBsAg HCV HIV 1-2 was negative. ESR was 10, means it was normal. Okay. ABG picture shows respiratory alkalosis. Now CSF analysis report shows increased protein level, which was more than 50 mg per dl. Increase in TLC count, which was more than 100. It was around 374, which is written in the reports right now. Sugar was also 34.1, which was 60 to 70% of plasma glucose. Polymorpho neutrophils is 28%. Turbid appearance is there. So diagnosis with the help of CSF report is bacterial infection. On chest X-ray, there is raised hemidiaphragm. Overall diagnosis is tuberculosis, TB meningitis. Antibiotics given to this patient is injection Dexa, which is a steroid which is given to reduce hearing loss. Injection streptomycin, which is aminoglycoside, antibiotic is given. Injection moxiflox is given to treat TB-like bacteria. Tablet combitol is given to treat and prevent TB. Injection Imset is given to prevent vomiting. Syrup loose is given to prevent constipation. Injection Pantop is given to prevent GRD. Syrup Mucane gel is given to treat acidity. Injection Perinome is given to prevent patient from vomiting. And Sucrafil is given to treat excessive gas in stomach. Okay. So this patient was having hyponatremia. So the hyponatremia was existing for more than 2 days. So when hyponatremia is for more than 2 days, more than 48 hours, it is called as chronic hyponatremia. And my patient was having moderate from the classification of the hyponatremia. Okay. Now when chronic hyponatremia occurs, what we have to check? We have to check for seizures. If it is present, then there is no compensation phase here, it is acute hyponatremia. But if the seizures are absent, we have to check the sodium levels. If it is less than 120, then we can check for neurosymptoms which may be present, and we have to give patient 3% hypertonic saline infusion. But if the sodium levels is more than 120, we have to check for hydration levels. In hydration levels, there is hypovolemia, hypervolemia, and euvolemia. If it is euvolemia, there are no major neurosymptoms considered as SIADH, because of TB meningitis, one of the complication is there SIADH. फ्लूइड रिस्ट्रिक्शन कर दो और वैप्टेंस दे दो. अगर हाइपरवोलीमिया, जैसे मेरे केस में यूवोलीमिया था, हाइपरवोलीमिया है तो डायरेक्ट सॉल्ट रिस्ट्रिक्शन और वैप्टेंस. एंड अगर हाइपोवोलीमिया तो स्टार्ट ऑन 0.9% नॉर्मल सेलाइन टिल IVC इज वेल अप्रिशिएटेड. Okay, so this was really interesting case, and I really enjoyed it. I hope you have also gained some more knowledge after hearing this case. That's all. Dr. Muskaan is signing off now.